Hi guys, so the format of this video is going to be a bit different and I'm probably going to be rushing through this. It's 5 a.m. and I've got stuff to prepare for before my practical. So this is more of a diary entry. I think this is going to be helpful for the future students just to know what to expect when they go for their IM1 practical. So I had my first internal med practical yesterday and it was about cardiology, and I just want to summarize the things that I've learned so that you guys can have an idea as to what to expect when you go to your practical. And it's good for me as well because I could look back to my diary entries, like my video entries, and remind myself of what we've learned. So as I said, yesterday was my first internal med practical for cardiology, and we started talking about the heart. So the functions of like the circulatory system, which we all know, to pump blood throughout the body, to maintain blood pressure, for the exchange of gases and nutrients and waste products and stuff like that. And then we went on to talk about the cardiac cycle. So, the systole, which is the ventricular contraction, diastole, the ventricular relaxation. And I learned, which I didn't know in the past, which is really strange, that the duration of one cardiac cycle is 0.8 seconds. So again, the duration of one cardiac cycle is 0.8 seconds, which I didn't know, and now I'm going to remember from now on. And then after that, we talked about getting history from the patient. So the first thing you need to ask when someone comes to like a cardiology clinic or place is what their chief complaint is. Like, what is like going on with them? Why did they visit you as a cardiologist? Like what brought them there and why they're there. So try get the chief complaint, and then the next thing you need to ask is to explore the symptoms. As I said, we need to explore the symptoms like of their complaint. So for instance, they came in because of chest pain, and we need to ask certain things about the chest pain just to explore the symptoms a little bit more. So I go through this mnemonic called Socrates. So S is for sight. So like ask the patient, where exactly is the pain? Is it centrally? Is it in the upper epigastrium? Is it like posterior chest? Is it substernal pain? So you need to ask exactly where the patient is feeling the pain. And if it's more diffuse, then ask the patient to just point towards the general area of the pain. And then O is for onset. So when did it start and how did it start? So did it start when they were exercising, when they were going on their jog or like climbing up the stairs? Or did it start when they were like just watching telly or just in bed? So this is important because you need to determine if the pain is exertional, if it's related to exertion, or if it comes even when they're just at rest and not really exercising or exerting themselves. C is for character. So character, you ask like what is the character of the pain? So is it stabbing? Is it burning? Is it a dull ache? Is it sharp? Is it like a pressure pain, compressing pain, like an elephant is sitting on their chest kind of pain? So those kinds of questions. So R is radiation. So is it radiating anywhere? Is it radiating to your back, to your left arm, to your neck, to your jaw, to your shoulder? So we need to ask about radiation. A is for associated symptoms. So do they feel feverish? Do they feel like a sense of impending doom? Do they have diaphoresis with this? Do they get like nausea and vomiting with this? Do they get any syncopal episode with this? So just any other symptoms that came about with their chief complaint of chest pain. So Socrates. T is for timing. Is this pain continuous? Is it intermittent? Does it get worse over time? Did it get did it stop, then come again, or is it just continuous pain? Okay, so that's timing. And then E is for exacerbating symptoms, like what makes it worse. So does talking, laughing, breathing, jogging, climbing up the stairs make it worse? And what makes it better? So does resting or nitroglycerin or any other like NSAIDs, does that make it better or make it worse? Okay, so you need to explore the exacerbating and alleviating factors. And the last one is severity. So S is for severity. So just ask, in a scale of 1 to 10, 10 being the worst pain you've ever felt in your life, where would you put this pain? So these are just some of the things we need to ask to explore the symptoms. And then after that, we need to ask about their other present comorbidities. This is part of their medical history. And then after that, just ask about their past medical history as well, if there's anything that's relevant. And then after that, you have to ask for their social history, like lifestyle, smoking, tobacco use, illicit drug use, their job, like the stress levels in terms of like their job and the family life and things like that. So that's everything, I think. So it's just kind of basic. And then we went on to talk about some of the tests that we do. My notes are kind of not very clear. I put stress test here. So I think we spoke about different types of tests in terms of the non-invasive, the minimally invasive, and the invasive test. So for non-invasive tests, we have stress test. It can be done like either like an exercise stress test or a pharmacological stress test, which is reserved for patients who cannot exercise or cannot walk for some reason. And for pharmacological stress test, we use dobutamine as the pharmacological agent. And then we spoke about putting Holter monitors. So this is placed in patients who we need to evaluate for any arrhythmias. It's a 24-hour monitoring device to record. It's just like a 24-hour ECG monitoring. So this is called the Holter monitor. We also talked about a 24-hour BP monitor. So this is used to rule out any mask hypertension or and even white coat hypertension as well. So we talked about the tilt table test as well. A tilt table test is just diagnostic for vasovagal syncope. We talked about ultrasound, like as an evaluation for CAD and valvular diseases. And nowadays you could do ultrasound at the patient's bedside. So this is really, really useful, and it's becoming part of like the physical examination for cardiac patients nowadays, because it's so easy to do near, like just on their bedside. I put MRI as well. So this is mainly used for diagnosis of things like myocarditis or like aortic dissection. CT is a non-invasive way to diagnose like a CAD, and a more like a minimally invasive way to diagnose CAD is coronary angiography, which is also therapeutic. So coronary angiography, or PCI, can be used to diagnose as well as treat coronary artery disease. So I think that's everything. Oh, central line catheterization, again, minimally invasive. So it involves it's like a form of venous access, and we kind of stick this to like a central vein, so a large central vein, for instance, our internal jugular vein or subclavian vein or femoral vein, because if we do this, for instance, if we need to deliver like large amounts of fluids for fluid resuscitation, or if the fluid that we're administering would harm like smaller veins. It's also, so I put here, so if you put a Schwann-Ganz catheter, we can measure the central venous pressure. So yeah, my notes are a bit disorganized, but anyway. And then we went on to talk about ECGs. So, you know, ECGs, 12-lead ECG, we talked about the different types of leads. So precordial leads, like chest leads, we have 6 of those, V1 to V6. And then we have the standard leads, so leads 1, 2, 3. And these leads are also called bipolar leads because they have a positive and negative electrode. And then we have the augmented leads, so AVR, AVF, and AVL. And these are called unipolar leads. So we talked about the indications for a right-sided ECG. So if the person has dextrocardia, which is the transposition of the heart to the right side of the body, we need to do ECG on the right side of the heart. Also, to evaluate like right side MI, we need to do ECG on the right side of the heart. Okay. And then we talked about the different components of the ECG. So we talked about, firstly, we talked about the P wave. So the P wave, sorry, talking too much. The P wave is atrial depolarization, okay? So the normal duration of a P wave is less than 2.5 small boxes, and the normal amplitude is the same, so it's less than 2.5 small boxes. We also learned that if the P wave is wide, so a wide P wave means it's greater than 2.5 small boxes. So if you have a wide P wave, this is called P mitrale, and this is a sign of like left atrial enlargement. And if we have a peaked P wave, so a tall P wave, which means it's taller, it's greater, the height is greater than 2.5 small boxes, this is called P pulmonale, and this is a sign of right atrial enlargement. Okay, so just to summarize, if we have a wide P wave, it's called P mitrale. This is a sign of left atrial enlargement. And if we have a tall or peak P wave greater than 2.5 small boxes in height, this is called P pulmonale, and it's a sign of right atrial enlargement. So that's it. So for PR interval, the normal PR interval is between 3 and 5 small boxes, so 0.1 to 0.20 seconds. The thing with PR interval is if it's reduced, so if it's less than 0.12 seconds, so if it's less than 3 small boxes, then this is indicative of an accessory pathway. So for instance, like the bundle of Kent is an accessory pathway which can then lead to Wolff-Parkinson-White syndrome. If the P interval is prolonged, so if it's greater than 5 small boxes, if it's greater than 200 milliseconds or 0.2 seconds, then this is indicative of an AV block, so a first degree AV block. The next one we talked about is the Q wave. So the Q wave is the first negative deflection after the P wave. Okay, so to say that again, Q wave is the first negative deflection after the P wave. So the Q wave, the normal duration of the Q wave is 1 small box, so 0.04 seconds or 40 milliseconds. And the normal height of the Q wave is less than 25% of the R wave. Okay, so to say that again, the normal duration of the Q wave is 1 small box, so 0.04 seconds, and the normal height of the Q wave is less than 25% of the height of the R wave. So if we have a deep and wide Q wave, this is a sign of myocardial infarction. So if you have a deep and wide Q wave, it's a sign of myocardial infarction. If we have a deep Q wave but not wide, this is a sign of ventricular hypertrophy. So I think that's it for Q wave. So R wave, R wave is the first positive deflection after the P wave. Okay, R wave is the first positive deflection after the P wave. And then the S wave is the first negative deflection after the R wave. So to say everything again about the QRS, Q is the first negative deflection after P, R is the first positive deflection after P, and S is the first negative deflection after R wave. And for the whole QRS complex represents ventricular depolarization. And the normal duration of a QRS complex is 0.06 to 0.12 seconds. So it's between 1.5 small boxes to 3 small boxes in duration. Okay, so again, the normal duration of a QRS is 0.06 to 0.12 seconds. So it's 1.5 small boxes to 3 small boxes. If we have a wide QRS, it indicates a bundle branch block. If we have a tall QRS, this indicates ventricular hypertrophy. So moving on to the ST segment. So the ST segment always has to be in the isoelectric line. If not, then it can be either elevated or depressed. So ST segment elevation is defined, so we define it in different terms based on where you're looking at. So if you're looking at the limb leads, so the limb leads are, in the limb leads, it has to be greater than or equal to one small box in terms of elevation. So greater than or equal to one small box in elevation in more than 2 leads. So that's in limb leads. In chest leads, to define ST segment elevation, you have to have an ST segment elevation of equal to or greater than 2 small boxes in 2 leads, okay, in more than 2, in 2 or more leads. So I hope that makes sense. I'll just say that again because I just confused myself. So okay, ST segment elevation, we have 2 different definitions depending on which leads you're looking at. So if you're looking at the chest leads, the precordial leads, you have to have an ST segment elevation of 2 or more small boxes in 2 leads or more leads. In the limb leads, the definition of ST elevation in limb leads is you have to have an ST segment elevation of 1 or more small boxes in more than or equal to 2 leads. So I hope that's a bit more clear. Okay. So if we see an ST segment elevation, then this can be a sign of a STEMI, so ST elevation myocardial infarction. It can be a sign of Prinzmetal angina or variant angina or vasospastic angina. It can be a sign of early repolarization and acute pericarditis as well. So again, the four possible diagnosis or like indications of ST segment elevation. So we have an acute MI, especially STEMI, ST elevation myocardial infarct, acute pericarditis, Prinzmetal angina, and early repolarization. So ST depression now. So ST depression is defined as the depression of the ST segment of like 1 or more small boxes in more than 2 leads. It is the same in precordial and chest leads. You just need to have a depression of 1 or more small boxes in more than 2 leads. And the ST segment depression is indicative of ischemia, of a ventricular strain or hypertrophy, of bundle branch block, of electrolyte imbalances and drug toxicities like digoxin. So again, it's an indication of ischemia, ventricular strain or hypertrophy, bundle branch block, drug toxicities like digoxin, and electrolyte imbalances. And we have different types of ST depressions. We can have horizontal, downsloping, or upsloping ST segment depression. Sorry guys, I got a bit cold. So moving on to T waves. So T waves, they're a sign of ventricular repolarization. So we can have like different things that could go wrong with the T wave. So we can have like a biphasic T wave, which means that we have like a positive and then a negative deflection for the T wave. So in a biphasic T wave, this is a sign of ischemia. If we have tall, tented, peaked T wave, it can be a sign of hyperkalemia. If we have inverted T waves, it can be a sign of hypokalemia and also ischemia. So again, if we have a biphasic T wave, it can be a sign of ischemia. If we have a tall, tented, peaked T wave, it can be a sign of hyperkalemia. If we have inverted T wave, it can be a sign of hypokalemia and ischemia as well. So where are we now? QT. So now QT interval. So QT interval, it's the last bit of the ECG, guys. So QT, it varies. The duration of the QT varies depending on the patient's age, the patient's gender, and the patient's heart rate. And there's actually a formula to calculate this, but it's beyond the scope of the practical, and we didn't actually talk about this in the lecture. I just know that we have a formula to calculate QT depending on the patient's age, gender, and heart rate. So for QT, if we have prolonged QT, this can be congenital. So this can be long QT syndrome. It can also be a result of like antiarrhythmics like amiodarone that can prolong QT. It can also be a sign of like hypocalcemia. And a shortened QT interval is a sign of hypercalcemia. So just to say that again, QT interval varies depending on the patient's age, gender, heart rate, and if it's prolonged, it can be congenital. It can be long QT syndrome. It can be a result of antiarrhythmics like amiodarone that can prolong QT. And it can be a sign of hypocalcemia. This is prolonged QT. If we have a shortened QT, this is a sign of hypercalcemia.